Good afternoon, class. Last session, we spent a few minutes talking about the demand for health. And today we're going to spend a few minutes talking about the demand for healthcare itself. And if we go back and think about what we talked about during the last session, that the main driver was health status or health stock or health capital, depending on which terminology you want to use, because we're all born with some level of health stock or health status. That level, we can actually grow it over time until a certain point. And then at some point in our life, as we all get older, at least for most of us as we get older, for others, it could happen earlier in life and as you age and go into your senior years. But at some point, it starts to deteriorate for a lot of reasons. Could be some external reason, could be an episode that, a healthcare episode or a health episode that we have. But again, at some point, it starts to deteriorate. And if you remember last session, we talked about you've got your gross health status, you've got your, we'll call it maintenance, and then you've got the depreciation that affects health status. And at some point, you end up with a net health status. And basically, everybody wants to live longer. Everybody wants a healthy, happy life. And if you stop and think about it, even from an employer's perspective, they want a workforce that is extremely healthy. And healthy workforce is more productive just in general. Fewer days off spent for sick leave, fewer days off, kind of these, me kind of days that individuals take off, more of a behavioral health. They talk about mental health episodes if people need some me time. So there's just the healthier the population, the more productive it is, the longer lifestyle. And if you look at from just a welfare societal view, it's just better off for the U.S. economy at whole, the healthier our population is. And we talked about Dewar kind of breaks things out. She kind of looks at health, and then she looks at medical care, and then kind of a combination of health and medical care. She may not be, explicitly saying it, but the combination of those two pieces translates into kind of the overarching umbrella of healthcare. And we also talked about Grossman's model for investment, his investment model for health. We looked at the factors impacting that investment model, and we were talking about the income, especially disposable income, talking about age, talking about external factors. And the one thing that I want to touch on just quickly before we jump into kind of the drivers of demand for healthcare is I want everybody to understand that, again, I go back to the financial coin that providers and payers are struggling over. Then and let's just go to the provider side of that financial coin. And if you go back to your microeconomics classes and you think about it, what drives the revenue of the provider side of the house or the provider side of that financial coin? It's the price of the good or service times the number of units, or prices times quantities. That drives the revenue of the provider. If you flip it and go back to the payer side of the house, what drives expenditures? Prices and the number of units of a commodity that you have, that you are actually purchasing, in this case, purchasing from the provider side. So prices and quantities, they are the drivers of both revenue and also the drivers of expenditures. So what you have is sellers are trying to drive total revenue, buyers are trying to manage the total expenditures, and that's where we come up with the two sides of the same coin, and everybody's struggling over that. And for every dollar in that financial coin in healthcare, you've got your providers trying to maximize revenues and payers trying to minimize expenditures. And if you just take a step back and think about just the dynamics of the market for healthcare goods and services, you've got And we'll start kind of upstream with the providers, and the providers are sitting there looking at the factors of production. And if you're looking at their factors of production, you've got, number one, you've got labor. You've got medical technologists, you've got nurses, you've got billing people, you've got administrative staff. You may have some physician extenders like nurse practitioners and PAs, and that's driving the labor piece of it. If you look at the natural resources, you've got the office where they either have to rent or maybe they've owned it outright. They've either built it or they purchased it. You've got capital stock, and capital stock is usually provided to the provider. And again, when I'm talking about provider, I'm just focusing right now on individual doctors' offices or partnerships or limited liabilities, may even talking about a corporation where we're talking about a large multi-specialty practice. But when we talk about providers, it's you can expand it, or you can overlay it. Just not medical providers, but you've got hospitals, you've got ancillary services, you've got pharmacies. So anybody engaged in the production of medical care, the management of healthcare services, it's typical, and it's pretty much the same for everybody. And if you go back to the capital stock, you're looking at, generally it's provided by vendors. Vendors are selling them electronic medical records. They're selling them computers. They're selling them office management software. They are selling them different, lab radiology type machines to help expand their business. And then you've got overlaying all of these other factors of production. You've got the technology of the production process. And technology, we're not talking about iPhones and iPads and all the fancy technology. We're talking about how the production process, how the physician's office, or how the hospital, or how the radiology, or the laboratory, or the ambi-surg, or the pharmaceuticals, how they take all of these factors in production and they transform inputs into outputs. And that's the technology of the production process. And then finally, kind of hand in hand with that technology, you've got your entrepreneurs, the individuals that are constantly looking at the processes, constantly trying to improve the processes, trying to take a provider's process and make it more efficient so that a provider can either generate more output at the same level of input, or finding ways within that production process that maybe they can back off on the number of inputs and still get the same level of output. So that's what you're looking at on the provider's office. So providers are purchasers, they're buyers, they're buying labor, they're buying capital stock, they're renting office space, buying office space, they're paying people to manage their technology process. At the same time, they're sellers. They are selling their goods and services to the payer side of the house. That can be health plans, that can be government agencies, that can be individuals in the marketplace, but they are turning around and selling it to payers. If you're a health plan, and we'll just concentrate on the health plan side, health plans are buying goods and services from providers, turning around, and they are selling them to government agencies. They're selling them to individuals who may want an individual plan. But the majority of their sales are going to go in the private sector to employer groups. And employer groups are either fully insured, where they pay a premium, and for that premium, the risk is managed by the health plans, or they are selling goods and services. The health plans are selling goods and services, what they call ASO groups. Self-insured groups is another terminology for them. And what they're doing is they pay the health plan some administrative fee, and the health plan agrees to set up a network for them to process their claims, provide medical management for them, ensure the claims are processed accurately. And in return, these ASO groups take full responsibility of the actual cost of their health care. So that's the way it's all set up. And it doesn't matter whether you're one of the factors of production selling services to the provider, whether you're the provider selling to the health plan, whether you're the health plan selling to employer groups, everybody is being driven by the marginal decisions that you learned in your microeconomics classes. And everybody is going to continue to play in this field and continue to operate as long as marginal benefits are greater than or equal to marginal cost. Again, it goes back to your micro classes, kind of the three pillars of economics: opportunity cost, self-interest, and marginal decision-making. And with that, we're going to jump into and talk about the demand for healthcare. And if you've got access to the notes, you can go into the system and get the notes. I'm going to kind of follow the notes along here. Under the demand for healthcare, the first bullet point says input in the production function for health. There's no utility apart from promoting health. It's somewhat unpredictable, and we've talked ad nauseum about it being unpredictable. It's driven by illness, and the expenditure level is high. And if you take a step back and think about it, when you talk about the expenditure level being high, you're not just talking about the cost of, and again, I'll go back and we'll take the simple kind of example. And so I get up in the morning, I'm not feeling well, I call my healthcare provider and you tell them I need to come in and see them. And at that point, I know when I call, the chances of me getting a same-day appointment is slim and none. So here it is. I get up, I call them. They say, well, it's going to be 2 or 3 days before, we can see you, but, set up an appointment. And, I hope I make it 2 or 3 days before they see me. But anyway, take the appointment. And it's not just the cost of that office visit, because the cost to me of that office visit is only $10. That's my copay of the particular health plan I have is for a primary care visit is $10. But that's $10 out of pocket. But I have to step back and think about, I'm going to have to drive down there. So I've got wear and tear on my car. I've got the gas is going to take to get me there. The doctor's office where I go, this is Atlanta. You don't get anything free in downtown Atlanta. So I'm going to have to pay parking. I've got to be there 15 minutes ahead of time, or I get my hands slapped because, again, that doctor's time is extremely valuable. Doesn't stop to think about my time being extremely valuable, but with the doctor's office, it's like 15 minutes, or we're going to slap your hand. And so I get there 15 minutes ahead of time, and I usually sit in the waiting room, maybe 30 minutes, waiting for somebody to see me. They take me back and, they, put me on the scales and I'm weighed, and they take my blood pressure and all of that mess, to get you started. And they come in and they ask you this really intelligent question. Well, why are you here today? Well, I'm here today because I don't feel well. And, they kind of, usually it's a young lady, and she'll kind of giggle a little, and she'll, again, continue to take my vitals and input some stuff in the computer, and she'll go through this list of questions, are you still on these medications, and all of this kind of stuff. Has anything changed? Eventually, I see the physician. Physician checks me out and then gives me a treatment plan. Usually it's got some medication, maybe may need some lab work done while I'm there. If I need some kind of an x-ray or something, then I've got to go somewhere else and get it. But for me to go see my primary care doc from the time I leave home, where I live in Atlanta, till I get back home, it's somewhere between 2 and 3 hours. So I've got time invested. And again, I'm looking at the opportunity cost of that time. There's a lot of other things I could be doing, but at the end of the day, that's what you're looking at when you go to see the doctors. Or at least that's what I'm looking at when I go to see the doctor's office in Atlanta. Now, I can call today and they'll say, well, you can always go to the emergency room. You can always go to urgent care. And I'm thinking, well, last time I went to urgent care, I'm not sure the individual that saw me knew any more about healthcare than I did. And it still took me like an hour and a half to go to urgent care. And the urgent care office is just probably a mile down the road from where I live. And then I see this article, and I can't remember who did the work, but I saw this article over the weekend, and it talked about the average wait time in an emergency room to seek health care by state. And I looked at Atlanta, and it was 2 hours and 37 minutes. And I'm thinking, gee whiz. And I looked at the state of Tennessee, and it's 2 hours and 40 minutes is the average wait time if you go to the emergency room. So I guess where I'm going is the cost of healthcare and just the process of seeking healthcare really, sometimes you wonder is, the effort to get healthcare services and the demand for those healthcare services, is it really worth it in the end? And then we want to talk about derived demand for healthcare as demand for healthcare increases. So you're talking about as wages increase, there is a derived demand for healthcare. And as I said, it's time and it's price of healthcare. And want to step back just a little and wanted to make sure everybody understands what we're talking about derived demand, because we're going to use it as an example in other chapters in the book. And basically, derived demand, it's the demand for a good or service that results from the demand for a different or related good or service. And in the example that I just walked through, so my initial demand was for an office visit with my primary care doc. But while I was in there was a derived demand generated for lab work, some pharmaceuticals, and there could be also derived demand if you've got back pain. There could be a physical therapy visit. If you've got issues that the primary care doc can't come to agreement with and generate a treatment plan, they may refer you out to a specialist. They may send you for x-rays. So all of those types of services are considered derived demand. There's a demand generated for those other services because I went to see my primary care doc. So that's what we're talking about, derived demand. And then the third bullet point, it talks about technology driving the demand for health care and medical care and ultimately health. There's a high degree of correlation. And so when we're talking about technology, and at least technology in the sense that it eases, at least in theory, eases access to healthcare. I've got a little deal on my cell phone, an application that allows me to get in and schedule my doctor's appointment, put in my health card information, my health card ID, my group ID, who I've got the insurance with. And you can also get it on your iPad. Once you get into the doctor's office, especially if you go into an outpatient surgical center or a hospital, then you've got the technology. They're doing a lot of work now for robotics. You've got AIs coming on the scene, and you read all of these articles about how AI is going to revamp the healthcare system and how AI might be a better option than actually going to see a physician, which I'm sure a physician is just thrilled to hear that. But that's what you're looking at is when they talk about technology. And especially, as I mentioned earlier, when talking about the vendors, now they've got electronic medical record. I don't remember the last time I had a provider, whether it was a medical technician or a doctor, come in with a notepad and then scribbling down notes like in a paper medical record. Everything's done on computer. Everything's done on iPad. It feeds into this electronic medical record. Electronic medical record has the capability to what they call clone your medical record. So the electronic medical record can grab information from your last visit and put it in the system. And the only way that the medical record for your new visit changes is if something changes in that new visit that they didn't see from the old visit. So technology is really driving demand for healthcare because it, in theory, is making it easier to access healthcare. Then we talk about education. It says education is less predictable on the demand for healthcare, but education is, while it may not be a driver for the medical care portion of healthcare, it is going to be a driver for a lot of the parameters, or a lot of the drivers for just health status, because it's talking about nutrition and sleep and exercise and knowledge and efficient production of health, and looking at time horizons, and that they have probabilities of, if you're this sex and this age and maybe this ethnicity, here's the probability that this could happen to you at along this time horizon. And a lot of, and depending on what employer group you work with, a lot of the benefit packages that an employer group buys will not only have benefits for medical care, it'll have benefits for behavioral health, and it'll also have a benefit package built into it for like population health, health status, those type of services, where you can have a health coach, you can reach out, call this 800 number. If you look at the back of your medical card, call this 800 number, and you can talk to people about nutrition. And there's just a lot of goods and services, bells and whistles built in or baked into that benefit plan that your employer group has purchased for you. And probably 9 out of every 10 individuals that is covered by a health plan or a benefit package by an employer doesn't really even know what's included in that benefit plan. And because that, a lot of the service they just never touch. And then we talk for a few minutes about age and deterioration of health status. And that's not necessarily age driven. For a lot of us, it is. But you can have the onset of some medical issues earlier in life that may not be as common, and it's not going to impact everybody in the same way. Or you could be involved in an MVA, a motor vehicle accident. You could be hurt at work and it's a workers' comp. You could be, fall down steps at home. And there's just a lot of external type of occurrences that could impact your health status in addition to age. And then want to look at things like insurance, what type of plan that impacts the relative price of healthcare, and it's going to impact the demand for healthcare. If you kind of look at it broadly, you've got private insurance, which sells insurance benefit plans to employer groups, to individuals in the market. CMS is going to be sitting over here managing Medicare and managing Medicaid. You've got DOD sitting over here managing the TRICARE book of business for the active duty population and the retirees. You've got the Veterans Administration managing their piece of the pie. And so you've got a lot of different organizations and different types of health plans. And depending on the benefit package of your specific health plan, it's going to go a long way to driving not only the overall demand for health care, but certain pockets of demand for health care. And if you maximize your health status, and that's what the government, that's what health plans, that's what you as an individual should be wanting to do, is to maximize your health status. There shouldn't be as great a demand down the road for medical care, and in turn won't be as great a demand for health care. But before we get into a couple of other notions, just want to talk quickly about normative statements and positive statements. And normative statements are judgment calls, and they specifically revolve around how things should be. And that's what you find with government agencies, policymakers, social economics, welfare economics. They talk about how things should be. And a positive statement is talking about how things are. Talking about when an economist is doing hypothesis testing, those are positive statements. You're testing them, and it's trying to make statements about how things are. So just keep in mind, you've got, especially when you see the talking heads on, Fox Business News, and they're talking about healthcare, and they've got some individual from DC, and they're making comments about, well, this is what it should be for this population, and this population is underserved, and this is how it should be. They're making normative statements as opposed to positive statements. And we talked earlier about healthcare as a private good, especially if it's employed, or especially if it's provided by your employer. So if it's employer-based, it's a private good. You have some public type goods on the healthcare side. Again, Medicare, Medicaid, a lot of community clinics. And a lot of people will talk about healthcare being a luxury good. And it's a luxury good because the elasticity of demand with respect to income is greater than one. So it makes it somewhat of a luxury good. Now, I'm not sure in the grand scheme of things that I agree with that. If you go back to Arrow's article that was generated in the late 50s, early 60s, healthcare may have been viewed as a luxury good at that point. But I'm not so sure that it's that much of a luxury good in today's market, because through government intervention and through private insurance, for the most part, healthcare is available for a significantly larger number of the population. I don't remember what the current population of the U.S. is. Let's say it's 125 or 30 million, whatever that number is. You think about all the healthcare goods and services are going to be consumed by that many individuals, and it's a significant part of gross domestic product, and a significant part of the growth in the economy here in the United States. And when we're talking about demand of healthcare, we want to talk about the difference between, I guess we'll call it need and demand. Need drives health policy and the individual's demand for healthcare. Basically, individuals go to the doctors when they need to. They go to the doctor because they think there is a need to have someone with a greater knowledge of healthcare, or the greater knowledge of Medicare, see them, or medical care, see them. So what you've got is it is a need-based kind of demand, because they want to go. Consumers want health improvement and healthcare, and one avenue is through the opportunity to seek medical care, which will, in theory, provide improvement and help increase the health stock, and at least hopefully increase the probability of a longer, healthier life. And need implies addressing healthcare problems. People are the best judge of their wants. People, basic economics, basic economic tenet says that it's utility that drives choices within a consuming population. But to make decisions on what they want implies a degree of knowledge and education, which may not always be the case. If you look at demand, especially for a normal good, demand implies the willingness to seek something, to seek a good or service, and the ability to pay for that good or service. In this case, we're talking about healthcare. Needs and demands are somewhat contradictory. And it goes on to make, the text goes on to make another comment that says there might be a need where there is no demand, and vice versa. So you might have a need, but you may not have the money to pay for it, and so you don't go to your healthcare provider. Or you could be a hypochondriac who thinks they're sick all the time, and they make multiple, I don't want to say unwarranted, but they make multiple trips to the healthcare provider when there may not be the need to go see that healthcare provider. And so when you're looking at healthcare goods and services, it makes it really difficult to differentiate between the need for a healthcare good or service and the demand for healthcare good or service, because that implies a willingness to seek it and a willingness or ability to pay for that good or service. And I think where these two probably contradict in the greatest sense is more the underserved, more the indigent population, maybe not so much here in the United States, but more so in some of these underdeveloped countries, some of these third world countries where you have, the World Health Organization and Doctors, Without Borders that are trying to provide those goods and services. And you have the Red Cross and other agencies trying to help along the way. And the last thing I want to talk about is if you have need without demand or demand without the need or vice versa, you could end up with either unmet or excessive needs due to misinformation, to barriers to healthcare, to prices and income levels. And those are the struggles, those barriers to healthcare. Those are the struggles that policymakers spend a lot of their time trying to figure out with their economists in the back room. So they have a bunch of economists in the back room in the dark somewhere, cranking through spreadsheets, writing computer code, analyzing all of this, wealth of information to try to help policymakers determine how best to maximize the net benefit of healthcare goods and services to a wide variety of populations and a wide variety of consumers, not only within the United States, but on the global economy. And that is going to kind of wind us up at that point. And when I come back, we're going to talk about asymmetric information. See you in a few minutes.